Hi, good afternoon, and welcome to the next episode of the ReSPECT podcast. We're back talking about pros and cons and how to do a ReSPECT plan. And today we're particularly focusing on ReSPECT plans and people living with learning disabilities. And I've got some really knowledgeable people with me today to talk all about ReSPECT and learning disability. So I'll let them introduce themselves. Kate.
Hi, I'm Kate Allez. I'm a consultant clinical psychologist working in the local learning disability service.
Emma.
Hi, I'm Emma Husbands. I'm a consultant in palliative medicine and I cover the community specialist palliative care service across Gloucestershire.
I'm Ben. I work for Brandon Trust and I'm a team leader.
Thank you.
Hi, I'm Frankie, a learning disability matron at the Aspen medical practice.
Lovely to have you all here, and it's really exciting to have new faces today because it's lovely to hear things from a slightly different point of view. So I guess let's start with what's your guys' experience of ReSPECT when it comes to particularly working with people who are living with learning disabilities, or what do you think of it, or what do you want us all to hear first? Go on, Ben. I know you've heard some stuff from some of your clients that you work with, so maybe you could tell us what the actual people you're working with think of ReSPECT.
So we try to encourage that everyone that is supported have one, a ReSPECT form that is, just to sort of detail how they would like to be supported and if they should need a hospital stay for whatever reason, and we make sure that everything that they have is documented, because it's not necessarily just that it's somebody living with a learning disability. Quite often they might have like epilepsy alongside it or diabetes. It's there can be quite a long list of things that somebody has, which is very important that if they come from us to have a stay in the hospital with you guys, it's very important that you guys know exactly what their needs are so that you can support them effectively.
Absolutely. And as an emergency consultant, I don't get a chance to get to know them like you or anybody that has a longer term relationship. And therefore, I'm really reliant on that information on that plan, because as an emergency medicine consultant, I don't have the attention span to do over one page. So people have said on this podcast they wish it was longer, but I'm very glad it is only as long as it is. I'm quite happy to have stuff stapled to the back to give me more details, as you do all the time, Emma. What would you like to say?
Yeah, I mean, I think that the ReSPECT plan has a real ability to be a portal and a universal way into understanding that individual living with learning disabilities, to be able to think ahead for those emergency situations. And fundamentally, that's what a ReSPECT plan is. It's a recommended summary plan for emergency care and treatment. And we know that for people living with learning disabilities, sometimes there is value in being able to utilise services in the community, for example, as an initial assessment, where somebody may otherwise be sent straight into an ED situation. And by thinking about what is best for that individual, what they cope best with, the things that help them to feel more relaxed or better understood, and to do that in a period of calm when somebody is well, it allows us to think about effectively those reasonable adjustments that include what we should do in an emergency situation and how best to try and approach it. And ReSPECT is obviously a way of universally understanding and recognising that for health and social care professionals. As you rightly say, Tanya, I often feel I need to put something stapled on the back because the boxes are quite small. And as you've rightly said, Ben, everybody has lots of other comorbidities or other conditions that we maybe need to understand alongside their learning disabilities or difficulties. So it gives us the ability to introduce and then flesh out the detail a little bit in other documents if we need to. And there is a real potential for it to open the door to a lot of those wider services that might otherwise be underused.
Yeah, absolutely. Definitely.
Just thinking about the other documents, I guess we strongly advise all people living with a learning disability to have a My Health passport or a My Hospital passport, and that would certainly be a way of gathering views from the individual and the people that know them best to really flesh out that additional stuff. And it includes the physical health stuff, the medication and those sorts of things, but also the communication stuff. So how best to talk to me? What will you notice about me if I'm not okay? Yeah. How will you know that something's changed? How will you know if I'm feeling frightened? And what can you do to help me feel better? What's the best way to try and get blood from me? Those sorts of things should all be captured in that My Health passport. And ideally that's kept up to date and comes in with people every time they come into hospital or any other health setting, so that people can get that more kind of qualitative stuff, not the things you can find on the computer, but it's the person's voice.
Yes.
Yeah.
And I often say that, particularly in that first summary box, we often get a list of people's past medical history, which, people are not their health conditions. And yes, it's really useful to know about them. And particularly if all these different conditions are either coming together to make management more complicated or because they're more complicated versions of a condition. But actually those real world things that nobody ever writes down are the things that really change how we can make the experience of emergency care so much better for an individual. Frankie, what's your experience of ReSPECT?
Yeah, so I think it's all about, first of all, understanding the needs of people with learning disability. So we do know they have poorer physical and mental health, so they would most likely benefit from this proactive planning, like person-centered planning for ReSPECT form. So all about capturing what matters most to them and what's important to them, what their fears are. So just having that identified on the plan and just making sure that wishes are respected when it comes to it.
Oh, you're preaching to the converted. Yeah. I often say that the values and fears is the bit that I most appreciate on the ReSPECT plan, because you can provide first-class care when it comes to looking at numbers and test results and all the rest of it. But if you haven't paid attention to what really matters to that person, you can have really done the wrong thing. And that makes things so much harder to deal with. I had a patient in the emergency department not that long ago who was an older lady who I'd actually seen when I was in frailty, and I'd seen with her support worker and her next of kin, and we'd had a long chat around the ReSPECT process and filled in a ReSPECT plan, finding out what really mattered to her. And this was a couple of years ago, and she came back into the emergency department. I didn't recognise her at all, and the staff were really struggling to look after her. And on this occasion she'd come back in without any support worker and her family weren't there. And I wandered into recess and said to the staff, has she got a ReSPECT plan with her? And they said yes. And I sort of said, is it a good one? Will it give us some information that will actually help us? And they said, we think it's okay, actually. And it was only then when I looked at this plan, I went, oh, it's my writing. But it was so helpful because I'd forgotten everything we talked about at that time. But actually, knowing the nickname that she liked to be called, knowing that she happened to love toy cars, and they really enjoyed them and nobody had brought one with us, we could actually try and, or at least talk about it. We actually went and stole one from Peds in the end. But, just being able to have a conversation, talk to the person in a genuinely individual way made all the difference. But that nickname and knowing what they enjoy talking about makes such a huge difference. And then because we could calm them, we could then get some blood tests, which we did need, but we had all that other information as well.
Just thinking that some of that's about bringing the person to life, isn't it? It's a person living with a learning disability. It's not a list. It's not someone that is just a list of diagnoses, as you say. And we know that there's still a lot of unconscious, potentially bias towards people with learning disabilities and assumptions about the quality of their lives and assumptions that are sometimes made about what efforts, I guess, we should go to support people. But if you've got a nickname and you know that someone likes toy cars, that person becomes a person.
Yeah,
Absolutely.
And people are much more likely, hopefully, to be invested in doing the right thing for them, aren't they?
Absolutely. And I think it's really important that we acknowledge that anybody in an emergency is not themselves. And if you make a spot judgment on what you're seeing in front of you at 2:00 in the morning when somebody's feeling really sick, I guarantee none of you will look your normal selves or respond in your normal way. So having that picture of what somebody's usually like is so important to help us realise how off the baseline somebody is. And I'd go as far as call it prejudice. And I do. I find more and more often that I'm writing ReSPECT plans with really being clear that there's an awful lot we can do and we should be doing, and we shouldn't be bringing that prejudice. I know one of the things that gets raised to me a lot, and I'd just be interested to know your views, is GPs are saying to me particularly that they get a lot of resistance about not wanting a ReSPECT. You know, people living with learning disabilities are not wanting a ReSPECT plan. So talk to me about that, because I know I've got my views, but what's your experience on the outside world?
I think it's busting this myth, like it's do not resuscitate form. So that's what I get. So it's just, trying to convince them it's writing what actually matters to you. So when you're not able to tell us what you'd wish to happen, would you like a hospital admission? Would you like to be, just give. And it's utilizing their support staff as well, because they know how best to introduce this, having all these communication tools that can actually help them understand, timing the communication well as well, because if someone comes in, I had a patient who came in one time and, they were concerned about life, about death, and I'm thinking it's not the right time to introduce, like ReSPECT plan, because they'll be thinking, oh, so this is actually going to happen. So it's just utilizing staff members to introduce the topic. You can introduce it and then just keep following up. But yeah, so.
Yeah, I think that's really important, the keeping following up.
Yes.
And Emma will say it right again. I always get the words wrong when we talk about what ReSPECT stands for.
Yeah.
And I have to read it, and that's just a sign of my age or something. But nowhere does it mention death or dying in the title. No. It's your recommended summary of
emergency care and treatment.
Thank you. But emergencies can happen at any time, and that's not about death and dying. Yes, emergencies are more likely if you're coming towards the end of your life. And if we haven't talked about dying at any point, then by definition it's an emergency presentation. But I think that's really important, that it's best done when you're relatively well and over time. And I know you spend a lot of time adjusting ReSPECT plans over time, don't you, Emma?
Yeah, it is that continuity, and situations change and health changes and views and priorities change. Even in the context of how you have experienced an admission, for example, that might influence whether you feel you want to come back in, or if you do, how you want that to be adapted the next time. And there absolutely is the myth, and it isn't only in the world of people living with learning disabilities, it's in the world, that ReSPECT plans are only associated with do not attempt resuscitation recommendations and effectively staying at home at the end of your life and avoiding hospital. I think there is a real myth that that's what they're related to. And clearly when you have some kind of advanced illness, physical illness, actually often the conversation is more focused, because we know that there may be ceilings to treatment in relation to that condition. But we're looking at something that potentially has a role for anyone, because an emergency can happen at any point to anyone unexpectedly. And clearly it is never going to cover every single scenario or every single situation, and you're not going to put absolutely every priority that you may or may not have within a document like that, or within a plan like that. but it gives that real flavour of where we should start and the things that we should focus on and the things that we should enable. And certainly in the world of people living with learning disabilities, and often more complex physical disabilities alongside their learning difficulties, it's a real enabler to being able to identify this is the way to do this, the things that we should do, and also being frank about it, having those honest conversations with people important to that individual as well as that person about what medicine can or can't achieve, because it is far better to have those conversations in a cool, calm and collected situation rather than otherwise. But I've been having these conversations with people over literally a decade or more. So I think that's a real demonstration of the fact that they're absolutely not about writing people off and avoiding intervention. It's about targeting and focusing it.
I could see you nodding along, Kate. Anything you want to add to that?
I was thinking alongside that, some of the things that we're not very good at talking about with people with a learning disability. And we often, the sort of 3 secrets of learning disability things we don't talk about. One is disability itself. So we don't talk with people about what their disability means, what it is, the impact it might have, but also the opportunities that are still there for them. We don't talk about sex. That's not necessarily for today. And we don't talk about death and dying.
No.
These are all things that we don't tend to name or talk about with people with a learning disability. And so that means that both the individuals themselves and often the people around them find it difficult to even think about having these conversations because they're things that you just don't talk about.
And in many ways, an extension of that, by definition, is that we don't really talk about illness. We don't talk about having an accident. We don't talk about those things that could lead to potentially a deterioration and death, because actually that's all part of it, isn't it? If you're involved in, heaven forbid, a car crash or something like that, it can lead to a big change. And these are things that in society, ideally, we should all be thinking about anyway in the best of circumstances. So absolutely, it's normalising life.
Yeah, and it's the sort of things that I guess we might talk about with our partner or our spouse, or as you're getting older, you might talk about with your children. But for people with learning disabilities, those just informal conversations don't happen either. So it's really important that we capture it within that ReSPECT conversation and that ReSPECT plan, isn't it?
I think there's a lot of spouses and children that aren't comfortable with these conversations.
No, that's true.
Mine being, if my husband's listening, I'm sorry, but I'm talking about you again. But, and we're a superstitious bunch, us Brits, aren't we? Talking about death doesn't make it happen, just like talking about sex doesn't get you pregnant. But both those things get better if you're happy to talk to the people involved about what you want to happen, So, it's...
Education.
It is, and talking is nearly always a better thing.
And I think also respecting, literally, that it isn't going to be for everyone. So actually sometimes people may want electively not to have conversations, and that is within their right, and that's okay. We can introduce and we can come back to something at some point in the future, but it's not about forcing anybody to have any kind of conversation or discussion that they don't want to have. And one of the things that I think is another important aspect of ReSPECT planning, particularly for those living with learning disabilities and maybe living in a supported environment, is the value that ReSPECT planning can have for those people caring for them. Because actually, again, when somebody is unwell, they aren't their best version. They can't necessarily speak for themselves in the way that they might otherwise. And there's a real responsibility on carers and staff, isn't there?
Absolutely, yeah. And that's why I say it's educating care staff as well. I really like to utilize care staff as best possible. Of course, incorporating people with LD and with learning disabilities. But staff, because as you say, what's the ceiling of care? Because we've had like a patient one time who had ReSPECT form, but for a different thing and not for minor ailments, which does not necessarily mean they use the ReSPECT form. So blurring those lines and then just teaching them, if it's a cold, this is something treatable. So the ReSPECT is for this and not the other. So it's continuous learning and it's not set to stone as well. So it can always be reviewed and changed. Yeah.
And tiny nuances, but there's never a ceiling of care.
Yeah.
There can be a ceiling of treatment.
Yeah, treatment, yeah.
But actually those little words, those little changes in language, and this has absolutely been an evolution over my career of how we talk about these things that I would have used to say ceilings of care. And I don't say that now. I do say ceilings of treatment because it is that part of the ReSPECT plan. And that's a harder part of the ReSPECT plan, I think, sometimes. Maybe almost more so for those people who are quite well, is to try and expand on the elements of where the treatment side of things does have limits or can have adaptations. And in many ways, I think that's one of the biggest challenges for primary care services and medical teams who are very stretched to be doing something that does feel almost unnecessary when somebody is quite well. But it reaps rewards when somebody then is unwell. And that's where we can potentially really have big advantages if we have thought in advance.
Absolutely. I think it's really important also just to reassure people that they don't need to be the expert in every condition. So me, and I've said this before, as a hopefully competent, sometimes competent, normally confident clinician, I might well be able to advise on several areas or several conditions, but there will be still an awful lot of times where I need to phone a friend or get somebody else to help me with these clinical recommendations. And I think you saying you were talking about a cold, I think it's really important to acknowledge that we're never going to address every single possible emergency situation or illness or problem that comes up. And that's why the knowing the picture at the top, and you touched on this as well, Frankie, that the person that knows the person best can contribute so much to that summary and those values and fears. Maybe I can add some of the clinical recommendations, but I really need the whole team and people. The person doing the ReSPECT conversation needs the expertise of the individual, their family, and their support workers and carers to help make sure we've got the best possible information. I think I just wanted to continue that to people's experience of if somebody hasn't got capacity to have a ReSPECT conversation for whatever reason, but today we're talking specifically about learning disabilities. I've seen a couple of ReSPECT plans recently that written across the values and fears has just been written, patient does not have the capacity to express. Oh, good. I'm glad you're shaking, Kate. You've taken the bait.
No, that's not okay.
So tell me what people should be doing.
Well, I guess they could say the person doesn't have the capacity to consent, but then we do what's in their best interest and we do what we know and we talk to the people that we know that know them best. But also we try with a variety of different methods to gather that information. So we find some pictures, we watch some videos, we have some conversations, we use symbols, we ask them to put them in different places or to nod or to sign. We need to try everything we can to get that information from the person. And if we can't get it from the person themselves, then we go to the people that know them best. And that may be family, that may be support workers, because actually family live a long way away, and right now the people that know them best are the care providers and the support workers. And we've had some interesting conversations before with the hospital liaison nurses sometimes about the sort of the triangle of care, and maybe sometimes with learning disability it turns into a bit of a square because you've got the individual, the clinician, and then you've got family carers and paid carers, and knowing who to contact about what is also really important. So you might be phoning parents to find out about early history and things like that, but you might be phoning carers to say, can you bring their toothbrush in, please? Small things make a big difference, don't they? So knowing about who's the right person is really important. And then that right person may be able to facilitate that communication with the person with a learning disability to gather that information from them. But we need to try everything we can, all of those reasonable adjustments and that augmented communication.
Absolutely. And the truth is, we don't, in an emergency, always have the time to go through these augmented communications. So we need as much of it done beforehand to help us.
Yeah.
We know it's rubbish that we're not doing it, but we physically can't in that half an hour of
But
an
I guess
emergency.
that's where the ReSPECT conversation comes in, isn't it? Because we're doing it before they get to you when you don't have the time to do it then.
And also, if somebody does become unwell, it's seriously unwell, which, as we've said, is not the sole focus, but is important. We don't want to be having a significant conversation in that setting, because all of those people important to that individual may well be, as you've said, not round the corner. And they're incredibly important conversations, particularly where we are making decisions in somebody's best interests. We almost need to be even more mindful of making those recommendations and decisions in that situation. So thinking ahead, having a thought, it may change, but it gives you a structure for the unexpected event that you then find yourself in.
Yeah. And I think it's like being asked to show you working out when you're doing your maths at GCSE, you know, and that's why I really find it tricky when you've just got the clinical recommendation at the bottom. I'm never going to be able to see the working out, see what people value and fear, see what the picture is. If I've got a picture and values and fears and things that I can do to make people relax a bit more, I'll probably be able to work out a bit of a clinical plan. I love hints and tips. As I said, I don't know all of it, but I need to see the working out to work out if they haven't got quite the right answer at the bottom for me. What can I do to make it better? Ben, anything particular from you? Anything else that you've picked up from talking to you?
Yeah, well, with regards to sort of the getting the ReSPECT plans in place, one thing that did crop up a few times was that people found it difficult to get a GP to sort of put anything towards it because they go, well, we don't know them. And whilst that is true, like you said, it's about working as a whole, as opposed to just being like, oh well, I don't know, so I'm going to opt out of this. Like, do you know what I mean? Like, we also found a lot that, as again, it's been touched on. It's looked on a lot as a DNR. Yeah. People, the experience is it seems more like people are willing to put, like the GPs are more willing to put their sort of like work, put writing towards it when there's a clear cut, this is what's going to be happening in the near future, as opposed to over time, this is what the person might need. Do you know what I mean? Like, it seems it's felt more like it is that DNR side of things, as opposed to this is how I want to be treated as a person. The personal element gets a bit lost, if that makes sense.
Oh, absolutely. Emma, we will have GPs listening to this who may well relate to that, and I don't.
But
think
not all GPs. No? I will say we have actually had quite a few homes have specifically said GP was absolutely brilliant. It very much seems to depend on who you ask, if you know what I mean.
Yeah.
Some have had an absolutely fantastic experience, and it's just been, can we have this filled out? There you go. Whereas some people have had not such a great, not such a smooth experience of getting them filled out.
Yeah.
So it's not all bad at all by any means.
And anybody that's listening to it, we've got to congratulate them because they've come to listen to try and find out some more. So what would your message be to GPs that struggle in that situation or maybe have had that experience?
I think it's something about seeing the value going forward and the benefit to the wider system of that person and everybody around that person is huge. What's tricky is that you often don't see it. And actually a lot of GPs, a lot of services don't work out of hours necessarily. They aren't dealing with the unexpected event at 2:00 in the morning. That's just the way that their working pattern may fall. And almost if you aren't dealing with that situation or the benefit of that conversation in the moment, it doesn't hit home so much. It doesn't resonate so much. You don't see what it achieves. And so it's us all working as healthcare and social care systems to be able to bring a little bit to the party. And as we've often said before, ReSPECT plans should be a little bit tea-stained, a little bit moth-eaten, because they should evolve over time, and they should have different sets of terrible doctor's handwriting, because each clinician will bring their piece of the puzzle and piece of the pie. I'm not a respiratory clinician. I have some knowledge of respiratory issues and cardiac issues and so on, like you, Tanya, but actually I can guide and then get a devil in the detail from a specialist who can bring their particular area. And that's what we need to engender into us as a health and social care service. And I do think it is both aspects, that it can be really advantageous in the wider scheme of things.
Yeah. I know we've had specific concerns from some GPs about whether they have to have the patient sitting in front of them necessarily when they are presented with a piece of paper. And I just, from my point of view, and please correct me if I'm wrong, I always believe that if other people that are trained in completing a ReSPECT plan and understand the point of it and know how to write on them, have completed lots of other bits of information, and as long as I, as a senior clinician, if I'm being asked to sign it, as long as I've looked at the notes and I believe it's appropriate and I've got the information, I don't necessarily need the person in front of me to start having a conversation. And sometimes that conversation will go back via the team as well. Ideally, I'd have somebody right in front of me, but if that's really difficult, I think it works both ways, that actually we're working as such a big team. It's okay to take what's given to you. You don't need to go and check if the person will be really unhappy if their socks are taken off them. You can take some things as read, and as long as you can check that you have no reason to believe there's anything made up on there, I think it's really important that we have trust in all the people and come together. You look unsure, Emma.
Well, I think we have to be mindful of certain processes. So actually, if we're making significant recommendations, particularly clinical recommendations, we need to ensure that we've had either a conversation with that person if we can, or a conversation with those who are important to that individual or represent that individual if they hold deputyship or otherwise. And so there are some technical elements that are really important to work through. If somebody doesn't have any relatives or close friends who could maybe act as a next of kin, for example, if they lack capacity, we should be engaging IMCAs. So there are certain formal bits, we can't deny that, but I completely agree with you, Tanya. It can be a virtual best interest meeting in certain situations. It can be a stepwise conversation with that person in certain situations. It's pulling those strands of things together, rather than it necessarily being directly somebody sitting in front of you every single time. We've got to be realistic. We've got to be pragmatic. We've got to do things properly within that. But actually, we need to get things done. And in order to do that, we sometimes need to work as a team, but doing that with due process, I guess.
Yeah, I think it's important to know that it's their voice and their wishes that is being expressed on the plan. So not just the family wishes or carers' wishes. So that's why sometimes it's important to have that conversation.
And I think if you look in, you can, as humans, we generally know, is this the right thing? Does this feel right? Have we done as much as we should have done? Or am I doing a bit of a slapjab dash job here? And I think your internal barometer is quite important for, is this right? Just to finish up, I wonder if anybody has any particular resources that they'd like to point anybody at, any videos you've seen that are particularly useful to help people with understanding the ReSPECT process, or anything you'd like to recommend anybody goes and looks at after this?
Inclusion Gloucestershire have made some videos around the ReSPECT process, but I can't remember the exact details. But if people looked up or Googled or went onto YouTube and looked for Inclusion Gloucestershire ReSPECT journeys, then there are some videos there that are nice and accessible. And the hospital passport, or the My Health passport that we mentioned earlier, is also a really helpful tool to have alongside the ReSPECT form.
And I think as much as anything else, if you've never seen those documents, just go and have a rootle around them and see what's being asked for them. And we'll pop some links and things at the bottom. Emma, anything you'd particularly recommend?
Yes, Resource Council have got a lot of links, and actually some of the work in Gloucestershire has been advocated through the Resource Council, and we've worked with them. In terms of palliative care, there is the Palliative Care Learning Disabilities Association, the name of which I can't exactly remember, and they again have some specific resources around particular types of illness and so on that might need a particular conversation. But yeah, Inclusion Gloucestershire is a good place to start, as are the ICB web pages as well.
Yeah. Anything else you want to add?
No,
Frankie?
yeah, no, just yeah. So it's just introducing the topic, as we've said, and when we do the annual health checks, that's a very good opportunity to introduce the topic, and just keep revisiting. Yeah, carry on.
And I think the other thing is this is life planning.
Yes.
ReSPECT planning is life planning.
Yeah.
Life might include death at some point, will include death at some point for all of us. But actually what ReSPECT planning is about is life planning, and how you want to live your life is influencing how you might be treated in an emergency situation.
Oh, well, we can't finish on anything better than that. So I would like to take this opportunity to thank you all for your time today, and thank you so much for sharing your wisdom with us. And we'll no doubt be back for another episode soon. Thank you. Bye.